Okay, we'll go ahead and get started. Thank you for joining us this evening to learn more about Tangible Hydra-PEG. We're going to start the webinar with Kevin Bly, who is a Senior Marketing Consultant for Tangible Science. Kevin is a 35-year industry veteran involved in new technology initiatives in contact lenses, advanced refraction, dry eye, and other areas. Following Kevin, Dr. Stephanie Wu will present a case study on scleral fogging and the use of Tangible Hydra-PEG. Dr. Wu graduated with honors from the Southern California College of Optometry. She completed a cornea and contact lens residency at the University of Missouri St. Louis, where she was trained to fit highly irregular corneas. Dr. Wu is a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Society, currently serving as president. She has authored the Gas Permeable Lens Expert column in Review of Contact Lenses. She authored several articles for the Contact Lens and Cornea section of the American Optometric Association. And Dr. Wu currently co-authors the GP Insights column for Contact Lens Spectrum, and she is an active Gas Permeable Lens Institute advisory board member. Once Dr. Wu concludes her case history, Tony Caparelli, the Director of Project Management and Product Development of Xcel Specialty Contacts, will discuss the utilization of Tangible Hydra-PEG on specific lens designs and our consultant's approach to Hydra-PEG recommendation when solving problems. We'll go ahead and get started at this time. If you have any questions during the presentation, please type them into the chat window and we will answer them at the end of the webinar. Kevin, you can go ahead.
Thanks, Kim. I appreciate that. In 2011, three people with very distinct backgrounds entered into the Stanford Biodesign program. The three of them were Vic McRae, who was a trauma surgeon by training and finishing up his residency at USF. Brandon Felkins, who was a mechanical engineer by training and had worked on numerous medical device startup and consulting projects up until that time. And Karen Havasu, who was finishing up her chemical engineering PhD and also an MBA at Stanford at that time. The way the Stanford Biodesign program works is they would often get groups of students in and pair them up with diverse backgrounds and ask them to solve different problems that were occurring in the medical, ophthalmic field, which was the specialty or the concentration area in 2011. And strangely enough, Vic, Brandon, and Karen were asked to address the problem of contact lens comfort and dropouts in contact lenses due to really just the problems we have always had with contact lenses, where people have comfort issues, dehydration, et cetera. And that was the start of what was then optical dynamics and then turned into tangible science a number of years later. Their original mission as they were starting out was to improve the contact lens experience of people with rigid lenses. And that has evolved now to the vision of tangible science, where their goal is to create a family of groundbreaking products that make contact lens comfort and experience better for all people involved, the patients, the practitioners, and the manufacturers. And in essence, it's all about the tear film. So the way they addressed the problem was to look at what was going on with the tear film and see if they would come up with novel ways to help improve that. Contact lens materials, as we know, can cause all kinds of discomfort and tear film disruption, particularly rigid lenses, which are hydrophobic by nature. And as nicely as they can be produced, there are always microscopic pits and pores that are within the lens that can become an area for protein and lipid deposition. Increased water evaporation, friction, mucin layer, immune responses are all part of it. And that whole dynamic is even being more exacerbated in today's society, where we now have patients that are on digital devices for as many as 4, 6, 10 hours a day. And with the just difference in blink dynamics that we have currently, that's just exacerbating the problem that was already in existence. Tangible Hydra-PEG works in the following way. What they have discovered is a way to put an entirely new bulk layer of material on the lens. So it's no longer the lens material that's actually touching the tear and the eye. It's the new material that now encompasses that. They did it by looking at the chemistry first, which is figuring out how to actually grow a very thin layer of a hydrogel on top of those lenses. And then they did the biology piece, which was to figure out what different materials would interact naturally with the eye and improve comfort. The biocompatible material that they have in the Tangible Hydra-PEG encapsulates the entire lens front and back, and the polymer is covalently bonded so that it's permanently attached to the surface of the lens. It's a distinct material that has its own thickness, its own properties, and it all enhances the comfort of the lens, improving wettability, increasing surface water retention, increasing lubricity, reducing deposits, and reducing scleral lens fogging. Tangible Hydra-PEG is very unique in that the plasma that forms, excuse me, sorry about that. It's unique from plasma and other materials like that because it will hide the surface of the lens totally. It's made of polyethylene glycol, which we know is PEG, and that substance has been around in ocular lubricants for decades. PEG is known to improve lens surface wettability, tear breakup time, and really reducing deposits on the lens. What's even more proprietary about Tangible Hydra-PEG is the coating is about 90% water, and its PEG formulation is complemented by two unique polymers that are, again, proprietary to the Tangible Hydra-PEG mixture. And the coating itself will then go ahead and fill many of the microscopic pits on the lenses and build into a smooth, wet layer that is permanently bonded to the surface of the lens. Effectively, the tear surface from the hydrophobic material is shielded so that the only thing that is exposed to the ocular surface is the hydrophilic, very wettable, smooth surface that matches the natural environment of the tear layer. We have a couple of samples here, and you can see just the wettability when you're looking at the drop that is put on the untreated lens to the left side and the drop that is then put on the Tangible Hydra-PEG lens. It spreads over the surface of the lens very readily, and again, allows it to be coating it on both sides of the lens so that it's interacting naturally with the tear layer. Tangible Hydra-PEG also resists coatings, and what we're going to show you here is the lipid dye assay test, which if you're looking at three different lenses that are being dipped in here, this is not moving along as quickly as I like. The first one is an uncoated lens, and as you see it dipped in the lipid dye assay and then dipped to be rinsed, the lipid adhere to the surface of the lens. This next lens is a plasma treated lens, and again, the lipids adhere to the surface of the lens, and then when rinsed, still adhere to the surface of the lens. It's going to increase inflammation risk and also that. Now the Tangible Hydra-PEG lens is dipped into the same lipid dye, and yet when rinsed, you can see the surface of the lens comes clean quite naturally, again, reducing friction and inflammation risks. This last one is just a sample of a plasma-treated lens, and you can see the deposition and the lack of wetting on that particular lens. And this is the same patient with a lens now treated with Tangible Hydra-PEG. Before I turn it over to Dr. Wu, just a couple of considerations with Tangible Hydra-PEG. Obviously, when to consider it when you have patients with poor wetting, heavy depositors, people that have fogging problems, new GP lens wearers, in particular, anyone that's looking for a more comfortable lens. And when you look at other considerations as far as it, there are no known contraindications for Tangible Hydra-PEG and no change in the lens fit. It's available on corneal, scleral, and hybrid designs. It's applied to the lenses at the time of manufacture. Two caveats: it is more slippery when wet. People do have to take a little bit more time and care in learning how to handle Tangible Hydra-PEG, and some have reported that the coating thickness seems to decrease over time, and I'll address that in 2 seconds. As far as care systems, the unique Menicon pH Menicon system and the Boston Simplus system are both multi-purpose solutions that are approved for use with Tangible Hydra-PEG, and peroxide systems, the Clear Care and the Clear Care with Hydrolide, are also approved. As far as things not to use with lenses that have Tangible Hydra-PEG on them are abrasives, alcohols, polishes, Progent, or tap water. And indeed, if anybody has to take a lens out and rinse it during the day, absolutely they should be doing that with saline and, of course, not tap water. Lastly, as far as the materials that are improved, Tangible Hydra-PEG is improved on Contumac Optimum materials. They now have an agreement in place with Bosch and Lohm, and we expect at the beginning of 2019 that their materials, the Boston materials, will start incorporating Tangible Hydra-PEG treatment. And they have also are very imminently going to be signing an agreement with Paragon, and those materials will also be included with Tangible Hydra-PEG treatment. In addition, Tangible Hydra-PEG has its own daily cleaning and disinfection solution, which will be joining the product line in early 2019. And as we had talked about earlier, some patients that have said that perhaps they feel it's wearing down over time over the course of the year, we have now developed a monthly conditioning solution called Tangible Boost, which once a month the patient would just simply soak the lenses in the Tangible Boost solution, and it reconditions the surface so that they can continue to have the wow experience that they have with Tangible Hydra-PEG. And with that, I'm going to turn it over to Dr. Wu so she can go through the case history that she's presenting this evening. Thank you.
Thanks, Kevin, and thanks to Kim and Tony and everybody else with Xcel for having me this evening. So I have a case report. MT, she's a 56-year-old white female. She had been seeing us for about 20 years for her comprehensive eye exams and contact lenses. She does not see great out of her current contact lens, but she says that she does see better in her contact lens compared to her glasses. Her current prescription is minus 1150, minus 3, axis 180. And with that prescription, she's seeing about 20/40 minus. And then the left eye is plano at 20/20. Currently, she wears the Specialized, which is a custom soft lens with those parameters, and she sees about 20/30 in that lens. So over the years, she's worn different things. She originally wore gas permeable lenses, but she dropped out of those for comfort reasons. And then she was wearing soft toric lenses, dropped out of those because of fluctuating vision. And then we fit her into the Specialized about 4 years prior. So she had been wearing those for about 4 years until I saw her at this visit. So at the end of her exam, we kind of talked about her prescription. It hadn't changed a huge deal as far as glasses went. And then for contacts, I just kind of delved a little deeper to try to find out what kind of issues she's having as far as her complaints of saying that she doesn't see great out of her current contact lens. So of course, I want to talk about different contact lens options with her. The first one is to continue with the custom soft lens, but she complains that she does get fluctuating vision and she is experiencing more dryness. And she did say that the dryness has gotten worse over the past few years and it's more difficult, and she's had decreased wear time with basically any type of contact lens. So then I kind of talked to her about different contact lens modalities. So we talked about going back to corneal GPs. She didn't really have any interest in that because she had tried those before and she remembered that they were uncomfortable and that they popped out, things like that. We talked about hybrid lenses, which would also be potentially a good option for her. And then I also talked about scleral lenses. She decided to go for the scleral lens, not only because I thought it could help with the fluctuating vision, because with the scleral lens, it doesn't really matter how she puts it in. When she's blinking, the scleral lens, even if it does rotate, even though it has minimal movement, but even if it did, there would be not much change in vision. So that would help as far as we don't have to rely on any stability markers or anything like that for good vision. And then also because of the dryness, she had complained that over the past few years that her eyes just were getting drier over time. And I thought this could also help alleviate some of the dryness issues that she's having, because with scleral lenses, you've got that kind of saline bath that's kind of bathing the front surface of the eye, makes the eye feel really good. A lot of times patients that have soft contact lens intolerance and dryness are able to actually get more wear time and more comfort out of scleral lenses. This is just a picture of her right eye topography. So you can see she does have normal with the rule astigmatism, nothing crazy. So she does not have an irregular cornea. She has a fairly regular cornea, so it's not like we have to go to some crazy design or anything. And of course, with scleral lenses, there's many different options out there. So I decided to fit her into the Atlantis Scleral with a 7.34 base curve, 15.0 diameter, and a -4 power in the diagnostic lens. Now, because she's got a pretty normal cornea, I feel very comfortable fitting her into a smaller diameter lens. So 14, 14.5, 15, 15.5 would probably be some of the lenses that I would reach for a scleral lens in this case, because she is a normal cornea. If she had some sort of irregularity, we might want to go a little bit larger to help compensate for that. But in this case, she's pretty normal, so we'll just stick with a smaller lens. I also find that if you stick with something that is kind of a more similar size to what they're wearing or what they're used to, then they have less apprehension when we're fitting the lens and when they come in for their dispense. So with that lens, she had great centration and stability. The scleral lens was very well centered, wasn't moving. She did have some central clearance of about 337 microns. In this case, with the Atlantis Scleral, practitioners kind of fit in different ways. And for me, I feel very comfortable. 200 to 400 is fine for me, so 337 is perfect. She had great edge alignment, inferior, superior nasal temporal, so that was wonderful. And then she took an over-refraction of -450, and she was able to achieve 20/25 vision. So with the scleral lens, she's actually getting one line better than her soft contact lens. So we went ahead and ordered the lens. Basically, I kept everything the same as far as the base curve and diameter. The only thing is I added on that over-refraction, and then, of course, compensating for vertexing, so the -450, that would give you 425, and that's where I came up with the -825. And I decided to use Optimum Extra Material. Here's just a photo of the OCT image, so you can see the central clearance, 337 right in the middle there, and definitely no areas of touch, central or mid-peripheral. It's kind of a blurry image, but you can kind of see where the edge of the lens is. It's not compressing in to the conjunctiva, not causing any blanching. There's no edge lift, so I'm real happy with the edge alignment there. And then same thing, nasally, she's got some good edge alignment. Maybe, sometimes you can look at that picture and kind of get fooled. But really, when you look in the slit lamp, that's really what matters. So sometimes you can get fooled with some of these OCT images of, hey, that thing kind of looks like it might be compressing. But when I looked at her actual eye, it looked perfectly fine. All the blood vessels were running underneath that lens, no blanching at all. So we went ahead and ordered the lens, and then we dispensed the lens. That went very well. We did her insertion and removal training and reviewed the lens care. For her, it was very easy because she's already used to putting things in her eye, inserting, removing contact lenses. So her lens dispense went extremely fast. She had great vision, 20/25, and she didn't take any over-refraction. She did say the lens was very comfortable, and it was a very good fit. And so I said, okay, let's try this for a couple weeks and see what happens. So at her 2-week follow-up, she says, the lens is really great, but after about 2 hours, it kind of gets fogged up. When I take it out, there's little particles inside the fluid layer, so kind of like a hazy fluid layer. And then once I rinse it out and then put the lens back in, the vision is good again. But then it fogs up again after a few hours. So when patients complain of lens fogging, we really need to delve deeper because there's different reasons why that can be occurring. So some of the questions I always ask patients, does it happen right away, so as soon as you put the lens in, or does it take a few hours? Or does it take multiple hours? Some people say, well, I get fogging, but it happens 16 hours after I wear the lens. Well, that could just be because their eye is dry and they've overused their eye for the day. But if it's happening multiple times during the day and they're constantly having to take the lens out and rinse it off and reinsert, that could be really frustrating. Also, when you look at the actual lens, when they come in for their follow-up, do you see any oily spots or smudges or deposits or anything on the lens surface at all? That will tell you that it might be a surface issue instead of an actual posterior tear lens issue. Also, is there any redness or irritation that accompanies the fogging? If patients say, yeah, I get really foggy vision and I've got really red eyes, and then when I take the lens out, the redness goes away. That could be a fit issue instead of the actual lens material itself or the patient. And then does the foggy vision remain even after cleaning? So if patients are saying that they are getting foggy vision and even after they take the lens out, they're still getting that foggy vision, it doesn't really seem to go away, that could be a hypoxia problem. So it could be that the cornea is not getting enough oxygen. So that's why it's important to really talk to the patients and kind of ask more questions. So these are kind of two pictures. Basically, when patients complain of fogging, it's either one or the other. It's either a surface issue versus a posterior tear lens issue. The picture on the left is more of a surface issue, so you can see that that area is kind of not wetting well. Some of the areas are kind of beading up, not getting good surface quality. Whereas the picture on the right is showing you a posterior tear lens issue. So you're getting these kind of foggy, swamp-like little particles that are actually behind the scleral lens, and it's in that tear reservoir between the scleral lens and the cornea. So we kind of need to distinguish between the two. So for lens fogging, I love this comment from my good friend, Dr. Ryan McInnes. He said this at Vision Expo a couple months ago, and he said, lens fogging, it's either a me problem or a you problem. And that's what he talks to patients about. And I thought that was like a great analogy, and I really like where he's going with this. So if it's a me problem, meaning you as the doctor, that means that is kind of similar to post-lens tear reservoir. Whereas if it's a you problem, that is the patient's problem, aka a lens surface issue. So if it's a me problem, there's a few reasons. Basically, the posterior tear reservoir, it might be because the edge is too tight. I see this all the time where patients have fogging in that area, and just simply modifying the edges can help. There might be too much clearance, so there could be excessive clearance that's also causing some debris in that tear reservoir. So simply just adjusting the clearance and making it more shallow can definitely help. You can also try to change the filling solution. So maybe they're using non-preserved saline, that they're getting like inhalation solution. Maybe try Lacropure, or possibly changing them to like a more viscous solution, or maybe scleral fill. So there's just so many different options as far as filling solution goes, so you can certainly give patients different options to try. You can also change the material. So with scleral lenses, you have to be in a hyper decay material, of course, to allow the most oxygen possible to the cornea. And I believe there's only about maybe 7 to 10 materials on the market now that are even eligible. But if the patient is not responding well to one material, you can always change them to something else. You can also try to change their cleaning solution. So if they are in a multi-purpose solution, maybe changing them to something that is more abrasive to kind of help get rid of some of those extra deposits, or maybe changing them to a hydrogen peroxide-based solution can help. You can also try to change the fit of the lens or change design. So in the case report that Dr. Ryan McInnes presented with this exact problem, he ended up having to change the actual scleral lens design, and then that solved the patient's issues. You can also add Tangible Hydra-PEG. this is definitely a good option for patients where you've tried other things, or maybe you don't try other things. Maybe you just do this straight off the bat. You're not even trying other things. So this can HydraPEG can really come into play at any point during this problem. Now, moving on to the U problem, that means it's a lens surface issue. So it's not wetting well, there's deposits, there's buildup, waxy surface, things like that. One of the issues is that the patient has some ocular surface issues. In that case, of course, you want to get them on a good lid hygiene program and get the meibomian glands taken care of, get their tear layer stabilized. You can also change their lid hygiene. So maybe they're using baby shampoo because that's what their doctor 30 years ago told them. So getting them onto more high quality products has made a huge difference in my patient population that have some of these lid issues. You can also try changing the lens material. I've seen some patients where they don't really have a lot of ocular surface disease problems, but they have these really, really bad lens surface issues, and simply changing the material, their eye just responds a little bit better. You can also try changing their solution. So once again, going from a multi-purpose solution to a hydrogen peroxide or vice versa, or maybe going to something more or less abrasive could help. Makeup is a big issue for a lot of my female population. I'm sure you've all seen it where some of them put the eyeliner right on the inner eyelid, covering up the meibomian glands. And I kind of think and cringe about it because I think I used to do that when I was in middle school, and I just think about all those meibomian glands I was plugging up and how disgusting that was every time I'm blinking and the oil's trying to get through onto my tear film. But if you see patients with lots of kind of waxy buildup, I mean, sometimes you'll even see the makeup on their actual lens when they come in. It's definitely worth a discussion on making sure they're putting the lenses in before putting makeup on. And then if they are using makeup, maybe just applying it in a different place, not right directly on the lid surface. Maybe even changing from one mascara to another could help. So makeup can definitely cause some lens surface issues. Soaps and lotions, you'd be surprised at how many patients they are cleaning and washing their hands with soaps that have moisturizing beads and just kind of oil-based things like that, or they're putting on lotion before they're putting their scleral lens in. And it seems silly because I know we learn about this in optometry school, and it's like, yeah, okay, move on. But there's so many products out there. If you go to the grocery store, and there's like hundreds of different soaps that you can use for your hands, and I doubt that patients are looking at the back of the label to see if there's any lipid-based or oil-based types of things. So, there's coconut oil and everything nowadays, it seems. So that's just something to educate your patients on, because that can definitely contribute to the problem. Lubricating drops can sometimes work for the lens surface, so sometimes their eye is just dry. You try all these different things, and just kind of lubricating the eye throughout the day and lubricating the surface of the lens can definitely help. And then this is not my patient, but the lens surface showed wettability, so meaning that when she was blinking and I was looking at the surface of her lens, everything looked pretty good, but it was the posterior tear layer that had actual debris. And you can kind of see in these pictures with the OCT, you can see some of those little particles floating around. And then in the slit lamp, you can kind of see kind of the little particles reflecting off. So in this case, we know it's a posterior tear layer issue. So because the fit was very good, it had good clearance and edge alignment, like that list I just showed you, I know that those are not the reasons why we're having some posterior lens debris. So the next step is I changed her filling solution. She was just using the Addy pack, the non-preserved saline, and so I switched it to Scleral fill just to see if kind of changing filling solutions helped at all. She comes back a week later, and she says the problem is still persisting. So I said, okay, well, it's not the filling solution. That's not doing the trick. Okay, next step, let's change the lens care. So she was using Boston Simplus. I changed to Clear Care, so a completely different cleaning method. And 1 week later, the problem was still persisting. So then the next step is I added HydraPEG to the lens surface. At her 1-week follow-up, she said after adding the HydraPEG, she said, I have no more problems with foggy vision. I can wear my lens for 12 hours per day without removing it. Remember, she was having to take it out every 2 hours. When I did the slit lamp exam, it did show decreased debris in the posterior tear lens. There was still a little bit, but significantly less than before. And she's been in this same lens for 8 months and hasn't had any issues at all. So just some pearls. Basically with fogging, the patient and practitioner can kind of choose what change is best to try and eliminate this issue. And sometimes it just comes down to the easiest and most convenient. So that's kind of why I changed the filling solution. That's something that I had in my office. Let's just try it for a week and see what happens. Then moving on to same thing with the care system. So let's just try it. I've got it in my office. Let's see what happens. Whereas when you're changing the material or adding a coating, sometimes that can be an extra step. And some of these patients, as you know, they're very reliant on their actual lenses. A lot of them can't see anything without them, so they can't really be without their lenses for a week or 2 weeks or however long it takes the lab to get to them. So just kind of talking to the patients and figuring out what option would be best for them can help. And then there's lens warranty restrictions. Each lab has their own method of applying the HydraPEG. They've got their different restrictions on changing the material. They all have their different warranties and things like that. So just get real familiar with your lab and find out what they do and don't allow and in what time frame. So sometimes changing the filling solution and the care system or the material will help. But definitely adding HydraPEG anywhere in the fitting process, even with the first lens fit. So I have a lot of friends that right off the bat, they are just ordering HydraPEG on every single gas permeable lens that they have now and scleral lens. They just automatically order it because they firmly believe in the properties. And I can tell you that a lot of my patients that have had a lot of issues, not only with debris, or wettability issues or comfort issues, they definitely notice a difference when you add the HydraPEG. And so why wouldn't I add HydraPEG to all lenses? Well, for me, it comes down to cost. HydraPEG is something that the lab will add for you, but most of the time there is an additional fee to the lens. There are some labs where it's actually included. So in those cases, I would say 95% of the time, yes, I'm going to get HydraPEG added to my lens because it's of no cost to me or my patient. But if the lab is charging me for HydraPEG, I am going to pass that charge on to my patient. So that's why I don't just add it on to every single lens right off the bat. Although, like I said, some of my friends, that's just what they do now, and that's just becomes their practice. And don't be scared to ask your consultants, Xcel, other labs. They are just fantastic people to work with. They know their lenses inside and out. They know exactly what you can and can't do. So if you ask them and you send them pictures and say, hey, my patient is getting these fogging issues, and here's what the OCT is showing, and this is what the slit lamp is showing, and get their opinion, because they get these calls every single day, and they are dealing with practitioners from all over, and then they're getting feedback on what is working and what is not working. So they might have an idea for you that maybe you didn't think about. So in the past, I didn't even think about changing the lens material until one of the consultants kind of recommended that for me. And then maybe right off the bat, they'll say, hey, I know exactly what this problem is. I really think you should add HydraPEG. Then you're not wasting time kind of doing all these other changes and wasting money too, and you can just kind of get to the root of the problem. So I definitely think from my own experience, HydraPEG is a fantastic option. I'm super excited that this technology exists for practitioners and patients, and it's definitely helped become an important part of my practice. So now I'm going to turn it over to our expert at Xcel, Tony.
Wow, I like that, expert at Xcel. I think it was great luck that Stephanie used our design for this. I don't know how that happened. That's amazing. No, thank you very much, Dr. Wu. I think you and Kevin hit on many of the things that we need to look at when we're talking about Tangible Hydra-PEG. So just a little bit about who we are and what we do. If you're not familiar with Xcel Contacts, we're part of Wallman Optical, an employee-owned business out of the Midwest that encompasses everything within the optical industry. And really where we strive to differentiate ourselves in the contact lens division is through education. And this kind of shows you the education that we stand behind and the types of products that we keep using and utilizing as we advance in this industry. I've been in the industry for 25 years now, and this is an exciting innovation for us in the GP business. We do about 1,200 gas perms a day. So it gives you an idea of what we're looking at. And I think Dr. Wu hit on it really well, that trust your consultants, because they're seeing or hearing about 30 to 50 patients a day, and they're consulting on these. So when we look at an innovation like this, we want to see for ourselves the advantages or disadvantages it. We don't jump in right away. We do our own clinical testing and do our own patient testing before we, as a company, decide that we're going to go through with something like Tangible Hydra-PEG. And we were one of the first labs to partner with Tangible on this venture. And Kevin hit on it with, patient dropout rate and comfort with gas permeables. Those are some issues that we had to address, and I think Tangible does that. Now, those 1,200 GPs a day, about a third of those are scleral lenses, and where we saw the opportunity with Tangible Hydra-PEG was with those scleral lenses. We have over 100,000 scleral lenses on eyes around the United States and internationally. And once that patient leaves your office, or once you fit that patient, it's really hard for the compliance to relay that compliance to that patient over that wearing time of that lens. And I think Tangible Hydra-PEG is a huge factor in keeping those patients, if they're not compliant in their cleaning regimen, or if they're not very good at that part of it, that Tangible Hydra-PEG can be something that we use on our end to help that. So the way our consultants position Tangible Hydra-PEG is not really as a problem solver. We want the problems to not arise. So what we do is we recommend it on all of the gas permeable lenses before there is a problem. So it's not as an after the fact problem solver, it's before the fact, so we don't see these problems. And where we really see the advantages are heavy depositors. Dr. Wu kind of keyed on it a little bit or talked about it. Why don't we put this on every lens? Because of the cost. Well, now that we've been partnered with Tangible for almost a year, we've seen, again, that we don't want to see those problems, and this can take care of it. The Hydra-PEG can take care of it on the front end. We may in the future just apply this to every lens. The one thing with that is that we've got to make sure that they're using the proper care systems with that Tangible Hydra-PEG. So if we can bridge that gap, it would be an advantage to us to put it on every lens. I will tell you that when we put the Tangible Hydra-PEG on a lens, if you request that, it is 100% guaranteed. If you feel like there was not a benefit to you or the patient, we will refund that add-on fee 100%. So it is no risk. If you haven't tried it yet, it's no risk to you to try it. We will credit that add-on fee 100%. So going back, the advantages, heavy depositors, and another condition, dry eye, corneal surface disease, all multifocals. We want to put the Tangible Hydra-PEG on there for that dry surface. We've seen a lot of patients with dry eye and corneal surface disease get fit in scleral lenses. And it is great for the back side of that lens and the saline and the tear that's trapped behind that lens. It hydrates the cornea, but you still have a problem on the front side of that lens and that side of it drying out. And that's where Tangible comes in. And we've seen a real advantage on those patients having that nice slick surface. And one of the other things I want to touch on is that this is a bond to the lens. So in our process, we actually take the lens and it goes through a plasma treatment first, and then it goes into the HydraPEG bath in that solution, and it bonds to the lens. So it's plasma treated first, and then the HydraPEG is applied, and it's bonded to the lens. It's only about 30 nanometers thick, but you can feel the difference. So if you haven't tried it yet, we highly recommend it. Again, it is fully guaranteed. It's not only a problem solver, but you can avoid those problems in the future. So now we'll open it up to any questions.
We do have a question. Is the Optimum the only material this is able to be put on?
As of right now, yes. As Kevin said, they do have partnerships with the Boston materials and the Paragon materials that will be in the future. But as of now, the Optimum materials are the only ones that it can be put on with Conamac.
Okay, I don't think we have any other questions. So I'd like to thank everyone for joining us. I'll be sending out a recording of this webinar to each of you so you have it and can review it again if you please. Please be sure to register for the remaining webinars in our Tangible Science educational program. They will be held in December and January. You can register through our website on our news and events page. If you have any questions or need additional information, please feel free to email me. My email address is on the screen, and I will get you an answer or get the information you need. Thank you for joining us, and have a good night.